Please, we are starting in the next 3 minutes. Just 5 minutes grace. We start so that we can finish on time and face other things. Please, Dr. Kechu, just hold on a little for us.
It's all right, ma'am. Sorry, are you? I'm not sure I can hear you.
Your mic is off, man. Good evening, man. Your mic is off. Can you unmute your mic?
Can you hear me?
No, I'm talking to Chief Ejinne.
Okay.
Hello? Can you hear me?
I can hear you now.
Yes, I can hear you.
can hear you.
Hello?
Yes, we can hear you. We can hear you, ma.
Hello? Can you hear me?
We can hear you, man. We can hear you. Continue.
Yes,
Dayo,
we are
can you hear
hearing
me?
you, ma.
Yes.
We can hear you, Chief.
Hello? Can you hear me?
Yes, ma. Good evening,
We
ma.
can
We can
hear
hear you.
you.
Can anyone
Good
hear
evening, we
me?
can hear you.
We're hearing you.
We
We're
can
hearing
hear
you.
We are hearing you.
Hello?
We can
Hello, we
hear
can
you.
hear you.
Yes. Yes.
We're hearing you.
Yes. I think I've lost you now. I can't hear anything you're saying.
Hello?
Hear you now. We can hear you now. Could just continue.
Okay, please, I sincerely want to apologize. I don't know what happened to my audio. Please, we are going to start. I'm really, really sorry. So I want to welcome all of us to today's presentation. We are privileged to have a seasoned radiographer in our midst. She's by name Dr. Priska Okechukwu. She has a specialty in chest radiograph. She's a lecturer in the University of Nigeria. And we are also privileged to have the head of department of radiography, Dr. Brooks, is also online. We are privileged to have some chest physicians, and we are privileged to have ourselves, the cardiothoracic physiotherapists as well. Today's presentation is very important because it guides our treatment. It guides patient review. It guides progress monitoring of a patient. Today, I'm sure that at the end of this presentation, we'll be able to appreciate X-ray more. We'll be able to appreciate disease conditions. And if there are questions that have been bugging your mind, you are privileged to have Dr. Okechukwu on board and the HOD and other professionals. So let's rub minds together. So Dr. Okechukwu, you are welcome and the floor is now yours. Please, let's kindly mute our mic. Once anybody enters, let's mute our mic so that we can hear her. Thank you very much for accepting to do this for us. The floor is yours now. Thank you.
Oh, thank you so much for having me here. I believe everyone can hear me, right?
Yes, we can hear you.
All right. So good
Yes,
evening,
we can
everyone.
hear you.
And thanks for coming around for today's study. So today I'll be discussing on the topic chest X-ray. And I am Okechukwu Priska Oyinye by name. All right, so let's get into the study. Well, I'm glad that this is an interdisciplinary study. We have people from everywhere. So it would be good to discuss our very own chest X-ray. That's one of the basic things that we do. That's chest X-ray. So I start by saying chest X-ray is one of the radiological exams that we undertake that produces a 2D image of a 3-dimensional body. And this image is gotten using an ionizing radiation. But it's so interesting sometimes when we have other professionals come around to the department to accompany a patient, especially the nurses. I know we have some of them here, other health practitioners. It's so amazing the way they conduct themselves around the X-ray units. And sometimes, one begins to wonder, excuse me, what about us working here? Are we not safe enough? So people just come around like, that's the patient, they run away. Like all of us are already emitting radiations. Oh no, I believe at the end of today's study, you will just understand some of the basics of what we do and when there's risk and when you are not in any risk. Of course, if you follow our normal X-ray radiation safety rules, you are not in any problem. Just being a patient or a patient relation, being a patient relation or just coming to the department with a patient doesn't mean you end up getting irradiated. No. So by the time you bring your patient, the patient is called in and you are now asked, the radiographer, of course, will tell you when to leave the room. And as long as you are in the waiting area is a very safe zone for patient relations and other patients that are not immediately attended to stay. So as long as you are there, you are fine. Because sometimes we start doing this our kind of run that even the patient that will bring to the department will be like, what about me that you're leaving here? Am I fine? Am I safe? So just knowing that X-rays are only produced at a point that the radiographer goes into the console after he or she must have positioned the patient and press the exposure button. That's the only time that X-ray is being produced. There's no radiographer that will allow you to stay within an unsafe zone at that point. Even if there's a need for you to assist a patient, you'll be given a lead apron to help protect you. So that's the way of introducing our general department and what we do and how we come about producing these X-rays. All right, so we're talking about chest X-ray tonight, and we know that for us to be able to appreciate the images on a chest X-ray, it takes a kind of a sequential approach. So we normally use a structured approach because if you don't use a structured approach, you're just looking at everything at the same time. You're just seeing shades of white and black, or you're even seeing like a skeleton that's colored in white and black, or you're thinking you're seeing the heart, or you're seeing, but even among the things you're seeing, there may be other things. So if you use a structured approach, it helps you to look at these things, every image, every structure you're seeing on the chest, step by step. That way, you'll be able to know what is normal and what is abnormal. So the clinical details of our patients are very necessary anytime we want to interpret a chest X-ray, because what the patient has been going through or things happening to the patient helps us to be able to come down to a particular diagnosis. That's why in the department, the patient presents without a clinical history, of course, we're going to ask you to go back. But thank God for, these days that we are now digital, we can access a patient folder for the departments that are already having e-folders. So you can go there and get those things. So if you're asked to, just know that it's very necessary. If it's not necessary, we will not ask you, because sometimes you have to match what you're seeing on the radiograph with the clinical presentations to be able to come to a conclusion. All right. Let's talk about the basics that are involved in an X-ray. X-ray, like I already said, uses ionizing radiation to create an image. The body is a three-dimensional structure, but the X-ray you're seeing is just a 2D image. So the three-dimensional structure we're having already superimposed on each other. That's why we have different views. The different views helps us to look at the particular body parts that we are X-raying and be able to have a full view of it. Like chest X-ray, we have the two views that we have basically is the PA or AP and the lateral view. So looking at these images in different view helps us to be able to have a full view and a full structure, be able to see all the structures that we need to do. But of course, it's not in all circumstances that we do the different views. It all depends on what we are looking at. So the images that you see on an X-ray film, of course, appears as black, gray, and white. So with time, by the time you keep training your eyes and keep understanding these structures, you will know that different shades of black, different shades of gray actually mean different things. For dense structures on the body, like the bones, they appear white. Why do they appear white? Dense structures tends to absorb more X-ray radiation. So by the time they absorb more of the X-ray radiation, the emergent beam, that's the beam that is coming out, is less. So by the time it interacts with it, the receptor, you'll be having it appearing white. Why on the opposite, lens-less structures allow the X-rays to pass through. So you're having a lot of the emergent beam. When they interact with the receptors, they appear as black. Medium density structures like soft tissues, they appear, in different shades of gray, depending on how dense. Of course, they're appearing to be more dense, their shades of gray will be tending towards white. As they're appearing towards less dense, they'll be appearing more black. So this chest X-ray that we're talking about, these images can be a conventional X-ray image or a digital X-ray image. I know that in most places, what you have here now is conventional, but whatever one you have, the major thing is that you have a good image of optimal quality. You'll be able to assess. Of course, we have digital image. It has its own advantage over conventional X-rays in that the contrast is always better. Like we have our photos, where you have your normal photos that you just do and print, and you have your digital. In digital, that reminds me about pictures that we have now. By the time they fine-tune it and all that, so that's also an advantage in digital images. Some of these images can, the contrast and the resolution can be played on for us to have a better image. What's the importance of chest X-ray? Why are we here talking about chest X-ray? Why do people go to the hospital for chest X-ray? One, chest X-ray is used to assess the thorax and its contents. We know the thoracic cage, we have all the structures there, we have the lungs, the heart, and the others. So normally we use this chest X-ray to assess this thoracic contents. Normally we use it for medical fitness. I'm sure everyone here, as long as you're working in the place, you must have done a chest X-ray, if not for anything, for medical check. So we use it to look at the patient fitness. Are you fit for the work? Is your heart fine? Your lungs okay? Hope you don't have any of these diseases that you may not be productive at work. So we use it to check how fit is this patient. Sorry, is this staff that's coming to work with us. We use it for routine medical checks. People go for checks just to see how fine they are. Some of these ailments, if detected early, can be taken care of. So people go for routine check to see the state of their hearts, their lungs, just to make sure that everything is fine. For chest X-ray, normally once a year routine check, it's fine. Then for pathological checks, when the patient has a problem, presents to the hospital, the doctor may want to do a chest X-ray, especially if it's a chest pathology that the doctor is suspecting. The patient can be sent to the X-ray department to, help rule out or confirm the diagnosis of the physicians. Of course, medical follow-ups. If a patient has been diagnosed of having one ailment or the other, as the treatment progresses, chest x-ray is also used as follow-ups to see if the patient is getting better or is getting worse. All right, let's look at the chest x-ray. So this is what you see when you have an x-ray. You can see this beautiful picture, you know, in shades of white and black. All right, so let's just quickly look at it and see the structures we can identify. Of course, remember, we're still going to take, you know, our time to step by step look at these things and know what's there. So this is a label diagram. So you can see the trachea up here. That's the trachea going down. And it bifurcates at the carina, goes to give the major bronchus. That's it here. So this is the neck region. That's the spine. We have the cervical at the point of the first rib, it becomes the thoracic. I'll have the thoracic spine going down. So this is, of course, a female patient. When you have the breast shadows there, this is the breast shadow that I'm outlining with my mouse. That's the next one. This tells you that this is a female patient. Then this area that is black is the lungs. Remember, we said less dense structures appear dark. So the lungs contain air. So we expect that it's less dense, that it will appear black. So we have the vessels. These are pulmonary vessels. This is the hila area. This is the hila area. These are pulmonary vessels. So, you know, it goes up to supply the lungs and all that. So these are clavicle. These are the ribs. We have the posterior and anterior rib. The ones going up from the spine, running this way, those are the posterior ribs. But these ones that curve inwards, there's the first anterior rib. You can see the next one, the second anterior rib, the third anterior rib. For the posterior, there's the first posterior rib, the second posterior rib, the third posterior rib.
I was writing. So the first one is if you want to.
Okay. Oh, so that means you have to look at this is the heart. This middle area is the mediastinum. This is the heart. You can trace that. This is the heart area. Right. Sorry, can you mute your mic so you don't distract me?
You can continue. I've muted the person.
All right. So this is the heart. As a white area, the heart is there, so that appears as white. So, you know, what helps us to different, you have the silhouette. So this silhouette is just the different densities that we're seeing, the ability for you to make out one structure on top of, we'll talk about it later. So I'll just use this to show us the major things that we see. This angle, we call it the postophrenic angle, the angle where the lungs mix with the ribs, the rib cage. Here is a postophrenic angle. We call this a cardiophrenic, or you can call it costocardiac angle. This angle where the heart meets with the diaphragm as a cardiophrenic, but where it meets, the diaphragm meets with the costal is a costophrenic angle. Okay, so we'll still talk about them in detail. So let's go. This is just for us to, you know, kind of look at these beautiful chest pictures that we'll be seeing and try to make out things from them. All right, so before we can actually look at the chest x-ray and be able to say that it's okay, or be able to say there's no abnormality there or there's an abnormality, we must make sure that the chest x-ray has a good quality, because a poor quality image can mimic a pathology. So for us to be able to check if our image is of a good diagnostic quality, we use the mnemonics called RIPE, R-I-P-E. R stands for rotation, I, inspiration, P, projection, E, exposure. So rotation, when you see a chest x-ray, you must make sure you determine, is there rotation in this chest x-ray? How do we know if there's a rotation? This is the chest x-ray I'm having here. This is the spine in the middle. So you can see the spinous processes. These are this green pegs you're having here is the spinous process of the spine here. Then can you see the clavicles this way? This is the right clavicle. There's a left clavicle. How do I know? There's a marker here telling me the parts of the body. So this is the right. This is the right clavicle. This is the left clavicle. Then you have to check this medial end of the clavicle, the distance between the spinous, the spinous process of the spine and this medial end of the clavicle must be equidistant in this and this. Sometimes they're not, excuse me, they might not be perfectly equidistant, but at least they should be close. So you can see the distance between X and Y. In this particular image, you can see the deviation is just a little, y is just a little larger than x. But when we have an obvious, when the distance between the two are really not the same, you have a disparity, an obvious disparity, then we do know that this patient is rotated. What will it help us do? We may have a tracheal deviation. So it may be just because the patient is rotated. So before you can confirm that there may be a mass or anything deviating the trachea that should be in the midline here, you must rule out the fact that there is no rotation. So first of all, check your images are not rotated. If it's not rotated, then we're good to go. The image is good on our first point. The second point, I have to check whether the patient inspired well. Chest x-rays are taken on deep, arrested inspiration. The patient is asked to breathe in and hold his or her breath, and we'll take the x-ray. So for us to know if there's good inspiration, we must be seeing at least 5 to 6 anterior ribs and 8 to 10 posterior ribs. I like to peg it at 9 or 10 if you're using the posterior, but most time the anterior is good for you to use to count. So the 6th anterior rib must bisect the midline of the diaphragm. So in this one now, this is the first anterior. Remember I said the anterior ribs are the ones curving in. This is the first anterior rib. Oh, sorry, forgive me. This is the first anterior rib curving in here. This is the second one, the third one, the fourth one, the fifth one, and the sixth one. So you can see in this image, the 6th is way above the diaphragm. So we have a good inspiration here. So you can see it was even the 7th that was bisecting the middle of the diaphragm. So you can see perfectly this patient has a good inspiration. So this one is a posterior ribs. You can see the 1st, 2nd, 3rd, 5th. So we should have at least 9 to 10. Some school of thought says 8 to 10. So, and now, because of an inspiration, you must also make sure that there's no cutoff as a result of a good inspiration. You must see the apices of the lungs. So make sure that the lungs apices are not cut off. I must see your costophrenic angle. These angles here, the both of them, they must be there for you to say, yes, this patient has a good inspiration and everything we need is in our film. The next one is a projection. You must know the projection that the film was taken in, because some pathological condition cannot be assessed in some views. Example, we have 3 projections in chest x-ray. We have the PA, that's the posterior anterior, meaning that the direction of the beam is coming from the posterior of the patient to the anterior. So the chest was close to the receptor. The next one I have here is a lateral. When the image is coming from the lateral, you're shooting from the one part of the lateral to the other. So the patient is standing in the lateral side and you're taking it from the lateral. And then last one is anterior posterior. If the patient is facing you and your receptor is at the back of the patient. So your beam is coming from the front of the patient to the back. So if the pathology here we are interested in is about the heart, we don't assess the heart with an AP film. Reason is, in an AP film, because the receptor is at the back, the heart is closer, is more anterior than posterior. So we have magnification because the object we are looking at is farther away from our receptor. So in that case, the heart may be magnified, but not really enlarged because it was an AP projection. So if we really need to assess the heart, we must take a PA projection. So that's why we have to know what projection was it taken in. So we don't assess the heart when we are having an AP film. The last one in assessing a good quality image is the exposure. You have to know, is this film optimally exposed? In an optimally exposed film, we should be able to visualize the pulmonary vessels, like I showed you, coming from the hila area. You can see the vessels moving down, some going to the middle lobe, then a few of them going to the upper lobe. So we're able to see the lungs field clear. The lungs field should not be too dark. We should be able to see the vessels and see through it, because if the film is overexposed, it will burn off those vessels. We won't be able to talk about the vessels, and they have to be so dark. And some minute lung pathologies may be missed. And if it's also if it's underexposed, it will be white, kind of soft. We call it soft films, and it can also mask some exposure. So we should be able to have the bones, the bony details well, in case the patient may have a fracture, you should be able to see it on the chest X-ray before you can probably, think of asking for other views for the ribs or any of the bony parts that's affected. Then the next thing is that the diaphragms should be visible. Then the vertebra should be barely seen behind the heart. So we know that we have a good penetration, that we can assess the heart well. Like I already said, overexposed film appear black, while underexposed film appear white. Now let's go down to a systematic approach on this image interpretation. So we've seen an overview of everything about the chest, how we now know that the chest is good. As when we picked up a chest X-ray, we're seeing some shades of white and black, and ascertain that this image have a good quality. And now we want to look at it and see, probably, is the patient all right, or what they wrote in the report as what is wrong with the patient. Can we see it? Is it really something? Or even if the patient doesn't have a report, can we quickly look at that X-ray film and see, I think this patient might have this or that. Or maybe we should have to, get down to the radiology to really seek their opinion on this. So for us to be able to systematically interpret the chest image, we use an ABCDE systematic approach. So many other approaches. We have an ABCDEF approach and other, but I want to discuss the ABCDE systematic approach. Here I have A as the airways, B breathing, C cardiac, C D diaphragm, and E everything else. So when we want to assess the airways, we have to look at the trachea, the bronchi, the carina, and the hila structures. When assessing the breathing, we have to look at the lungs and the pleura. It's worthy to note that normally in normal healthy patients, the pleuras are not visible. So by the time you start seeing the pleura, something's already going wrong. Then the cardiac, look at the heart sides and the heart and the heart borders. If you're not seeing the borders well, it shows something is going wrong. And if the heart size is away from the normal size it should be, it points out to something that's going wrong. Then the diaphragm, the costophrenic angle, you're able to clearly see the diaphragm well. I'm able to assess what's inferior to the diaphragm and the costophrenic angles. They are very, very important. So any film that has a costophrenic angles part of should be repeated, because some pathologies actually, for one of their first sign is the blunting of the costophrenic angle. So we must make sure we have a sharp angle there. If the angle is approaching 90, there's a problem going on there. If it's also not sharp, there's a problem. So we need to see the diaphragm well. We talk about these things in details later. So everything else, so when you're done assessing those ones, you look at the bones, the soft tissue, the mediastinum contours, and some review areas. So look at, are there tubes in this patient? Are there pacemakers? Are there valves? Because in some, some X-rays, you see like some ring things around the heart, like we do in our CTU that we do pacemaker. Some patients have pacemakers. Normally it's inserted just below the clavicle, and the main disc is there, and you can see the wire going down to the heart to connect. So you can see some valves there. Even they do valve replacement, you can just see them as rings around the heart. And how other tubes? Some patients have ECG tubes. We don't remove those things when you want to do a chest X-ray. No, it's contraindicated. You must leave all the valve. You don't just go and remove the ECG tube because you want to do a chest X-ray. They're out there. So your ability to know how they look like tells you nothing is going wrong. They're just ECG valve tubes and or pacemakers, as the case may be. Okay, let's go down to the airways. When we want to assess the airway, so we'll look at the trachea, carina, and bronchi. Let's follow the red arrow in this image is showing us the trachea. Like I said, most time it's central and it's going down. Normally, it can be deviated a little to the right at this point because of the aortic knuckle. The aorta, knuckle is here. So sometimes you have a little, if you follow this my cursor now, you can see it's going down here, comes to this point, it moves this way, down before it deviated. So you can have this small deviation, that's normal. Then carina is the point where it bifurcates. This point that the trachea divide into the main bronchi. That's where the green arrow is showing this carina. The bronchi is when it bifurcates, and we're having the pink arrow is showing us our bronchi. And the hila structures, this is where we have the pulmonary vessels. This is the hila, this is the right hila, there's the left one. It's from there the pulmonary vessels comes out and it starts, going to distribute and supply the lungs. Okay, so I'll be discussing some of the abnormalities. I'll help us to see the normal and show us an abnormal so that we'll be able to appreciate the normal from the abnormal. So let's look at this trachea. So we're seeing the trachea moving down. It's colored blue now. You can see it's coming down at this point of the carina. It bifurcates, goes down this way, and so that one, that's the arc of the aorta. So you can see the normal. But let's look at this patient. In this patient, you see this is the trachea. See the trachea has been massively deviated. And look at it going down this way. So many things can make the trachea deviate. The trachea can be pushed away from where it's supposed to be or pulled towards the other side. Anytime you have things occupying, let's say one part of the lung, you are having a content that is not supposed to be there, maybe air or fluid, and they're now occupying the space. Let me use on the right. If I have it more on the right side, what it does is that it will push the other structures towards the left. So you are now having a deviation to the left. But when you have the normal structures on the right, for any reason, reducing in size, then in that case, it has reduced the space there. What will normally happen is that the structures that are supposed to be midline are now drawn towards that space because there's a vacuum now. So they are drawn towards that. So if the trachea is deviated towards the normal side, you already know that that means in the abnormal side, it's having a content that is there that's pushing it away. If it's drawn towards the abnormal side, that means something has happened to that side that has reduced that space there, that is making it pull the medial structures towards it. I just hope that's clear. In this case now, we are having a we're having pneumothorax here. What happens here is that we're having excessive air in the pleural space. So because it's occupying so much of this space now, it's pushing the trachea towards the right side. How do I know this is a pneumothorax and it's not a normal air in the lungs? If you look at this lung now, we're just seeing all the blacks here. There's no vessel here. If you look, the normal vessel, okay, let's use this one. You can see from the hila point, you're seeing the vessels, these white stripes moving up, supplying the lungs. But if you look here, there's an absence of any hila marking. The vessels are not there. So telling you that this is just a free air in the pleural space. So because we have a lot of this air, it has pushed the midline structures to this side. You can even see the heart was also pushed to this side. We're not having the heart here. So none of it is on the left. We should have the heart to that side. Okay, the next one I have here, in this case too, this is the trachea. The trachea is now deviating to this side. And we can see this is the side that is having a problem, at least if not for anything. You know that normally the lungs here should be black. So what is going on here? Because it's now moving to this side, fluid also appear white. But if it's a fluid that is occupying this place, it has a content. It can stay in a space. So there is a content there that is abnormal content. So you should push it to the other side. So the fact that it's not being pushed to the other side, rather the trachea is now being pulled to that side, tells me this is not a fluid. Rather, there's a loss of volume here. What can happen for us to have a loss of volume? If the lungs collapse. So we're having a total lung collapse here. The lung has collapsed and the space is now reduced. There's nothing there. Naturally, these structures here will shift to where there is space. So that's why we're having this deviation to this side. This is my next image. We're having pleural effusion here. How do I know it's a pleural effusion? And fluid appear white, and you can see this trachea being pushed to the side. So it can be collapse. If it's a collapse, I expect this guy to start moving towards the empty space. So in this case, so these three scenarios I just painted are things that can deviate the trachea to any of the sides. Okay, let's look at the carina. What's this carina? Like I said, is a point of bifurcation of the trachea. The cartilage at that point is called the carina, so it takes its name from there. The cartilage at this point of bifurcation is called the carina. It comes and bifurcates into two. This is very important when we're assessing, because especially in children, you know, when it comes down and it's bifurcates into two, the right and the left, the right is wider and more horizontal, while the left is narrower and more, the right is wider and more vertical, while the left is narrower and more horizontal. The implication is that most time in children, for inhaled foreign body, because this space is wider and more vertical, you can see inhaled foreign body lodged here in the right bronchus. So when we're assessing, we have to look through and make sure that this space is clear and we are not having any soft tissue mass lodged in here. The next one is the hila. So the hila area, this is the hila area where the vessels come. Remember, our trachea comes, but the bronchus is one of the major contents of the hila. We have the pulmonary vessels. These are the pulmonary vessels. This major bronchi, the right here and the left here, and some lymph nodes. Then important to note that in normal patients, these lymph nodes are not normally visible. By the time you're having the lymph nodes here enlarged, they become visible and you will have hila enlargement. This normally happens in malignant conditions. So instead of having this width for the hila, you will see the hila well enlarged. So because most of those lymph nodes will become inflamed and they will become large, and you can now see it. It's also important to note that the left hila is normally about 2 cm higher than the right, but most times they have the same size. So by the time you look at this hila area and one or both of them is now massively looking more enlarged than normal, then you know that there's a pathology there. The next one is breathing. You have to assess the lungs and the pleura. Remember I said the pleuras are not normally visible unless there's a pathology, like we see when there is pneumothorax shifted, we're seeing the pleural space without having the hila markings. So normally for us to assess the lungs, we divide the lungs into 3 zones. The upper zone that is having purple, the middle zone, that's the green area, and the lower zone. Remember, these are just the zones for interpreting. We know the lungs, the left lung has just 2 lobes, and the right has 3 lobes. These are not just the lobes of the lungs, rather the zones that we use when we're assessing it. What does it tell me? I come to the upper lobe and start looking at it and comparing the right upper lobe with the left upper lobe. If they're supposed to be uniform, but like we know some structures, like when you come to this middle and the lower lobe for the lungs, of course, the heart in most patients, except for patient that has dysarthria, is more towards the left. So you accept that you know that the heart, of course, is around this area. So you don't expect to see as much lungs, excuse me, as much lungs around there than you have on this area. So aside for those normal variations, so you look at if there's any abnormality. They should know that sometimes some of these abnormalities can be bilateral. So the ability to know what is normal helps you to know when there's a bilateral abnormality. So when you look at this upper lung zone, you're looking at it. Are we having any cavitations? Are we having any calcifications? Is there any white patches? Is there anything? Is it darker than normal? You know, just look at this apex well and look at it. Then you come to the middle lobe and look at the middle zone, and look at it and assess and check. Our hila areas is one side larger than the other, you know, that kind of thing. You now come to the lower and look at the cosophrenic angle. Are they blunted? Are they okay? Are we seeing an acute angle like it should be? Or is it blunt? Is it blunted? Most times it's pleural effusions that will blunt it out. You won't be able to see that angle. So when you look at this area as well, you'll be able to, you know, assess the lungs very well. Instead of just looking at the lungs and say, this is the left lung is okay, this is the right lung is okay. No. If you take your time and look at it, you'll be able to pick some minute differences, and that can be an early pointer to an abnormality. Okay, let's look at these images. We want to assess, like in this first one, let's assess the upper zone. This is about the upper zone. If you compare this area with this area, one that are not uniform. Then I look at it and give what's going on here. If you look well, you will see there's a cavitation here. So this pulmonary TB. In pulmonary TBs, we normally have cavitation. So even if you don't know what it is, remember this interabdominal, this really, that's why we have specialties. But at least you'll be able to know that there's something wrong going on in the upper lobe there. So this next one, you can see, if you compare the upper, the middle, and the lower, around this middle area, we are seeing a difference here. Normally, there's an opacity here that is not here. So we know there's something going on. There's a consolidation around this place. If look at this third image, you can see around this area. I'm assuming that I'm just trying to run because of time. First of all, you go through the upper zone, lower, middle zone, and I'm just trying to point out the areas we have problem. Okay, in this other one, you can see here, we have this opacity, and there's blunting of this, the border of this heart. Normally, when you see this, the right heart border.
Please, but we are not seeing your.
So you're not seeing my cursor?
Yeah, the slides.
We are seeing everything. Maybe it's your network.
Please, kindly log out and log in again.
The slide is showing. Maybe check your network.
The slide is clear. I'm okay.
Okay.
We are seeing the slide here. We are seeing it.
Okay, let's continue, please. Thank you. Okay, in this last image, you can see these two white arrows showing you there is something here. If you compare here with this area, we're supposed to have a good long shadow in here, but we're not having it. And you're seeing this white opacity here. You can see this consolidation. Let me just call it opacity. And it's blunting this right heart shadow. So most time, the things that affect the right heart border, it's really a middle lobe collapse. When there's a middle lobe collapse, this part of the middle lobe collapses, and we won't be able to have a good right heart border. Okay, let's go on. Now we go to the cardiac. We want to assess the heart. Remember I said you only assess the heart with a PA film. Make sure the film was acquired in PA. So in this PA, how do we assess we use what we call the cardiothoracic ratio. Like the name implies, the ratio between the cardio and the thorax. So we'll measure the highest diameter of the heart from this point to this point. You can see this maximum point. So we'll just draw a line up, the next line up here. So we'll take this distance. Now the cardiac ratio. Then from this point of the rib cage to this point, just from the maximum diameter of the lungs, we take this distance. So this over this should not be more than 0.5, as it should not be more than half of it. Anytime it's more than half of it, already patient is having cardiomegaly. There are so many things that can cause it. You know that the right heart border, like I said earlier, is mostly shown by the right atrium, while the left heart border is a left ventricle, is what we are having here. So when you assess that, even sometimes, merely looking at it like this patient, when you use your eye to assess it, you know that of course it's less than, but you can't do a normal assessment by using the eye. You have to measure it. You use ruler actually to measure it and take the ratio before you can be able to stick out your neck and say, yes, there's a cardiomegaly here. Then the next one is the diaphragm. You come down to the diaphragm. The diaphragm is what we have here with the yellow arrow. There's the diaphragm. There's the diaphragm. So the diaphragm must be sharp and well visualized. If it's not well visualized, it's telling you there's something that is going on. And it must have this angle too, because in some cases where there's atelectasis, I believe, when the alveoli are collapsing, so the air is being trapped in the lungs. So normally air coming to these alveoli, when you breathe in, when you breathe out, it releases this thing. But when they start collapsing, they're able to take in air, but they can't take it out. So those alveoli are collapsing and forming large, air bags there. So when the patient expires, in expiration, you will still see that the lung volume is still much. So in such cases, you may have this diaphragm blunted. You won't be seeing this angle sharp like this. It's kind of coming down because of the pressure of this air that is being trapped inside the lungs. So the next place that we should also look at for is this angle that is in pink, the schizophrenic angle. So if there's a fusion, no matter how small, you will see it here. If it's a mild effusion, you can just see just a small blunting of this schizophrenic angle. It may just be starting from here. Look at the angles are not sharp. It can just be small pleural fluid that is there. So we'll look at for this. And normally, here that we'll talk about this diaphragm is also very good to look at for it, because normal on the left you have the stomach here, so you can have the fundal gas around here where we're having the red arrow. If you look at somewhere around, depending on the patient, if has been fasting, if he's not eating, just normal. When you're standing, any air that is in the stomach goes to the fundal area. You've seen them as black. But when you see some air trapped under the diaphragm, is an indication of a pneumoperitoneum. You know that the bowels are here. So if for any reason there's perforation of the bowel, the air in the bowel leaves the bowel and is now a free air in the peritoneum. So if the patient is standing erect, what it does is that normally air moves to the highest point. So it moves up and you start seeing it here. So like we have in this black arrow, there's fluid under this diaphragm. So this is a free air in the peritoneum. We call it pneumoperitoneum. This is an emergency situation. When you have a patient having a pneumoperitoneum, you have to, really send in the patient to the physician. They may have to go in for repair, so the patient won't die. Can actually lead to death if not well taken care of. So that's why you have to look out under the diaphragm, look at the schizophrenic angles to check if there's any of these abnormalities. Then the next one is everything else. We look at the mediastinal contours. Permit me to use this, our chest to look at the mediastinal contours. These mediastinal contours, just around the mediastinum. Is the mediastinum okay? Is it widened? It's also important to note that in supine films, the mediastinum is normally widened. So if whatever you're assessing is about the mediastinum, just make sure that the film is not an AP film. If in an erect film, PA film, you're having this mediastinal line here, like the cm, if you have more than 6, so it's not supposed to be more than 6 cm. But for any case where we have it more than 8, then there's something going wrong. So the physicians has to look at it. Then the next one is aortic knuckle. This is an aortic knuckle where the aorta folds. Of course, you have the ascending aorta, it goes up, folds and becomes the descending aorta. In patients with cardiac diseases, you can see aortic unfolding. You will see that this aorta is really unfolding. It's very pronounced and enlarged. Also, it happens with age. As the patient's age is increasing, you see that there is prominence of the aortic knuckle. The next one is aortopulmonary window. This window is actually this space between the aortic knuckle, and the hila area. This area, sometimes you have some abnormalities there. There's some notes around here that sometimes when especially in malignant situations, it may become enlarged, and this angle, you'll not be seeing it, is a pointer that there's something going on there. Then the bones and the soft tissues, of course, you should be able to look at the bones well. Just follow the bones. These are posterior ribs. Make sure there is not, especially in cases of trauma. Patient can have a blunt trauma and you look at the ribs, nothing. But a fractured rib, even if there's no pneumoperitoneum, there's no other chest abnormality, having a rib fracture can make you know that this patient should be monitored, because it's possible it fractured and it has punctured the lungs, but it's not, we've not have enough damage to be shown radiographically. So we have to look at the bones and make sure there's no fracture of the ribs, the clavicles are intact, and the visualized scapulars are okay. The spine, everything was seen, it's fine. And the next one is tubes and valves, pacemakers. When you look at it, like I already explained, patients in the ward, patient in ICU, we have the pacemakers there. So when you see those ECG lines, just know that they're normal, they're just pacemakers, they're not vessels going wild. So it's just normal. So I'll still show some of the images where I have some pacemakers and the ones that have ECG lines and others. So those are the things you look out for. So, having seen that, let's quickly review some radiographs before I take some questions. So in this radiograph, I don't know if I should ask or just keep on presenting. I normally teach, I like to ask questions just to be sure everyone is following, but I think I just have to talk. Okay, if you look at this other one now, you can see this is an ECG line. There's an ECG, I look at the wire going down this way. There's another one. So this is another tube here going, probably an oxygen pipe, or it's going down this way. So this is just for some of these things. But when we look at this lung, I have here pneumothorax. You remember I said when we are looking at the lungs, we look at it, we must make sure we're seeing the vessels. If you're looking at this left lung, you can see this looking so beautiful, like a beautiful chest. But if you look at it, there's no vessel. We're not seeing the vascular markings. There's a hila here, no hila on this area. So that tells me something is wrong. And when you look at it, there's no vessel, no upper lobe vessels, no middle lobe vessels, and no lower lobe vessels. And now you're seeing this, they call it consolidation. When you look at it very well, you know that there's a lung collapse here. The lung has collapsed and shrunken, and this is just the part of the lungs that is remaining. So this just pneumothorax says there's air in the pleural space, so it has squashed the lung and collapsed the lung. So that's why just having this free air here. That's why you're not having any vessel like we have in this other arm. You can see the hila, you can see the vessels going down here. Look at the other vessels, these are the vessels, but it's not the case in this other side. So when you see something like this, this is a case of a pneumothorax. Pleural effusion. If you look at this, there's lots of lungs. You're not visualizing the lung at all in this one. The angles are gone, and can't even visualize. This case is because of the massive fluid here. There's a complete pleural effusion on the right lungs. So that's why it's appearing like this. This film is well penetrated because we can barely see the spines. Look at even the ribs coming up, but we're not seeing any of the lungs. So because there's fluid here, there's massive fluid. So normally they have to drain and start draining out the fluid so that the patients get better. This one is pneumoperitoneum. You remember what I said in pneumoperitoneum? I said pneumo, air in the peritoneum. When we have a free air in the peritoneum, of course, when you look at this, this is a bowel. You can see it appearing with its normal postural markings, bowel appearance. But just under this, the free air that we have in the abdomen here has floated up against the highest space that it can attain. So that is what is lining this area. So this is pneumoperitoneum. The next one is a pulmonary congestion. So we have pulmonary congestion when, most time in cases of pulmonary edema, when we have in pulmonary edema, when we have a lot of fluid in the pulmonary vessels, there is congestion there. If you see the hila areas are all enlarged, you can see the pulmonary vessels become very prominent, and you can see what we called apical diversion. These vessels start moving, towards the apex. Normally, you don't, see a lot of these vessels going to the apex. You just see some going but they're not as pronounced as we have. So you can see everywhere, all those vessels are all enlarged, all engulfed, and so very pronounced. So that's what we see in pulmonary congestion. This image is having a long tumor. Let's look at it very well. Look at the red arrow. Okay, what if I say it's a pneumothorax? Can it be a pneumothorax? That's all. No, okay. Let me say lung collapse. If it's a lung collapse, this is the collapsed portion, the remaining part of the lungs, then that means I won't be able to see this hila markings here. Look at the vessels. So if I'm seeing vessels here going down, that means this is still part of the lungs. So that this is not a lung collapse. So that means this, I see our vessels going up. So this is the whole of the heart. Whatever is going on here, it's inside the lungs. So this is a lung mass. It's a tumor in the lungs. Okay, this is just an image that I have that is showing the pacemaker that I told you about. So this is the disc of the pacemaker, normally inserted below the clavicle. This is the disc. And you can see the pacemaker wire, of course, going in. You can see this one here, the other one here. So of course, when we look at, for sure, this is not an erect image. Of course, we can use it to assess the heart. Of course, the patient that has a pacemaker already know that something is already wrong with the heart. If not, there will not be any need for the heart. So if you also look at the heart, you can see that it's massively enlarged. I want to look at this area too. You see, blunting of the cosophrenic angle. I say the angle is not sharp. It's supposed to be having something sharp like this. So there is a small effusion here. On this side, not really, just a little. But of course, this is not really the problem of this patient. This patient has a lot of heart issues. So probably trying to see how the patient is doing. All right, that brings me to the end of the slides I have for us to discuss. So by the way of concluding this work, you know that X-ray is very important. It's a very important diagnostic tool. We use it to be able to assess what is wrong with the patient. We can, sometimes the physicians, they will think that probably there is this and that. By the time you do a chest X-ray and you know that the structures there are fine, then you know that you may be dealing with something lighter than what you think they are. So it really is a very important diagnostic tools that help us to be able to find out what's going on inside the patient's body. Like we know, radiography actually helps us to look inside the body. So when we look at you with our radiographic eye, you are seeing everything that is inside, and we can tell you what's going on. That's on a lighter note. Okay, so this chest evaluation is very necessary because it helps us to detect abnormalities. So anybody that wants to evaluate a chest X-ray, you should know that you just cool down, calm down, take it easy, and look at this thing. And if you miss a minor abnormality on a chest X-ray, I actually have done that patient a big harm, because in medicine, what we'll try to do is to pick it early as possible. There's a minute nodule that is there. If there's a microcalcification you missed, if there's a cavitation just small that you missed, or consolidation just there, and you missed it because you were not able to see it, you know what it means? Maybe you just tell the patient you're fine, the patient is not fine, I'll be coming back in the next 6 months. Something more horrible. So by being able to pick it out at that time, patient must have better treatment and of course be better. So follow-ups can easily be done with these chest X-rays. So I know how far the patient is getting on. Patient is getting better, it's getting worse. Can help the physician to continue the line of management, or of course change the line of management if they feel some of these things are what they're doing is not really helping the patient. And chest X-ray, like we all know, use lower exposure than other ionizing radiation examinations that we have. As it takes a lot. Of course, chest X-ray is a first pointer. It's not everything that some of those maybe you can see a nodule, you can see a calcification, you may see something, but we're not able to characterize it well. Patient may be sent for a CT, or in some cases that chest X-ray may not really give us exactly the details and what we want. Patient may go for CT, but chest X-ray is the first pointer where we start from, to be able to know what's going on. It's something that needs further investigation, patient will be sent for to, have the patient examined by other modalities like CT, MRI, and others. So chest X-ray is very, very important in assessing a patient's condition. These are my references, and thank you very much for listening. God bless you.
Okay. Thank you very much, Dr. Kechuku. That was really, really very, very impressive and informative. And I really loved your composure. You are presenting this as if we are eating salad. So I believe this is what happens when you are good at what you do. I really appreciate this presentation. I've learned quite a lot. Before we take questions, I just want to share a personal experience. It's very important that we as cardiothoracic physiotherapists get the skill of appreciating x-rays. That's the only way you will know whether your therapy is working. I remember someday that I was on call and we had a patient that had congestive lung. Of course, the physician had already outlined his line of treatment. Physiotherapists were also there doing our part. So after some time, the physician asked for a repeat x-ray. So when this x-ray came, it didn't come with a report. So there was confusion among the team members. Some said it has resolved. Some said the congestion has not resolved. In fact, to break the tie, the x-ray was sent back to radiology department, and he came back with a report that the congestion is resolving. And based on that, the physician changed his line of management and the patient got well. So you can imagine if there's nothing like x-ray, or if the radiologist or the radiographer did not come in to do that interpretation. So the patient could have continued taking the drugs that the physician had already prescribed. So chest x-ray is very, very important. And our ability to appreciate it can never be overemphasized. So, and on this note, I would like to take some questions, some comments, contributions. Someone had already sent in a question. Maybe we start from that, why others come. Someone, Chiamaka Onyeka, is asking you, how would you know something is wrong with the pleural space? I think I will also benefit from this question because I don't know. How do you know that something is wrong with the pleural space? Please, you can take your question while other people come up.
All right. Okay, like I said, normally the pleura, they're not visible. If anything happens and you start seeing, of course, we look at the edges of the lungs. If anything happens and you start having a thick line around that area, so know that there's some abnormalities that causes thickening of the pleura, they know that something is wrong. Or in cases of collapse, in cases of pneumoperitoneum, where the lung has been pushed out, so you're now seeing the pleura, having its content, whatever it is now, whether it's now the fluid around there. So know that there's something wrong. Just know that anytime you start seeing the pleura, like the normal chest x-ray that we see, all you've seen is just the lungs, still ending at that margin of the thorax. So whatever happens and you start seeing a thick line at that pleural line, there's something going wrong. So you need to send in for expert interpretation to know exactly what is going on. Hello? Am I still audible?
Yes, I can hear you.
Okay.
I'm
Okay,
trying
maybe I
to
should
see
some of the
those that
questions.
raise hand. Okay.
Okay.
Please
Okay, this
pardon
one
me.
said, okay, this question said, how can you differentiate some pathologies that are similar, like pneumonia and pulmonary edema? You know, some of these things, because you are not trained in this area, you know, what we do by the time we do some of these studies, just for us to know when something starts going wrong, and for us to know the, you know, the mild ones and the obvious ones. But for cases that are similar like this, you may really need to send in for an interpretation, because some of them, they present the same way. But like I said, in pulmonary edema, you're already seeing the hila full, but that is also for some very classical, very obvious one. There may be ones that may not be that bad, but it's still there. So you may miss it out, or you may confuse it for the other pathologies. So when these things are already in question, you may have to send in for reporting so that you don't, you know, get it wrong by thinking it's one, because they actually present the same. So how do you recognize consolidations in the lung? This one is very simple. You can know if there's a consolidation because the lungs fields normally should be clear. Having the black, you know, the air in the lungs field black, and the only white thing around there now is just the vessel. Like, just see that the vessels are coming from the hila area, and of course, more in the middle lobe going down, the upper lobe has less of those vascular markings. So by the time you start seeing patchy opacities, like you're seeing spots, or white opacities where you're supposed to be having the image of the lungs, know that there's a consolidation there. But then there are so many things that can cause consolidations. So the fact that you know there's a consolidation here doesn't tell you what it is. Maybe a middle lobe collapse, it may be a lot of things, that the differentials are many. But anytime you start seeing those abnormal white patches on the lungs, you know there are consolidations, so you seek for the radiologist's opinion. So I said, can you explain how select sign can help for differential diagnosis of different pathologies? What is even this silhouette sign that we'll talk about? These silhouette signs are, you know, different structures have different densities. That's how come we're able to, you know, see them, and how come we're able to know. Imagine that the heart has, every structure in the heart has the same density. You know, they either be all white or all black or all gray. So for us to be able to see, because all of them have different densities and their absorptions are different. So these silhouette signs are, we're able to see the heart because the lungs is black. So we're seeing the cardiophrenic angle, we're seeing the costophrenic angles and all that. So if anything happens, like we have consolidations, we have effusion, there's lots of these silhouettes. So anytime we're not having the cardiophrenic angle sharp, you know that something has happened that has changed the density of either the heart or the lungs, that is now making us, okay, let's look at that middle lobe collapse now. We're having loss of that right heart border. So we are losing the silhouettes there. So something is going on, because all things being equal, they have different densities. The heart has different density from the lungs. So we should have a good silhouette sign, have these good silhouettes, that the contrast should be very clear, that we know that this is the heart, this is the lungs. So anytime we lose those things, then that's the silhouette sign that we'll talk about. Just anything that makes us to lose those sharp demarcations that the different body density and attenuation coefficients has given us as that help. Then when I start talking about what pathology, you know, looks like, now we have loss of right heart, but most time is middle lobe collapse. So which silhouette is lost can tell, okay, costophrenic angle blunting, that tells you is an effusion. So different ones tells you what it is. Okay, here said, okay, it's important to understand normal precision even when you are can't put different position. Yes, I agree with you, Mr. Aaron. He said it's very important to understand the normal presentation even when you can't properly define a pathology. Understanding normal will help you when you should escalate. And that is actually the aim of this whole presentation. If you know what is normal, a patient comes in and you look at it, it's no, with this, something is going on here. Even if I don't know what it is, I know this is not the way it's supposed to be. So that helps you to escalate the matter. Just like in the X-ray department, there's something we'll see. A patient can walk in well and healthy, and walk in after the X-ray, he goes home and dies. But maybe you take the film, you look at this, he said, no, this patient, like that's pneumoperitoneum is an emergency condition. You look at said, no, you're not going home. With the film straight to emergency. Patient goes there, is admitted here. But patient is obviously normal. Doesn't mean that you will reach the gate. So what this helps you to do is just for you to understand what is abnormal. When we see those abnormals, we can escalate. Thank you very much.
Okay, I think we have
questions.
Joseph Chief, his hand has been up. I don't know if he still wants to ask question or whether you have been able to take care of it. Joseph, are you there? Joseph Chidi, are you there?
Yes.
Can you ask a question? Okay, shall you ask a question?
She has taken care of it.
Okay, please, Dr. Kechuku, can you tell us how we know there is metastasis in the lungs? So, and if you know anything about this bat sign or something, so please.
Okay, for metastasis, normally we have met. Most time is a lung metastasis to the lungs. It's still part of those considerations I will talk about. When you start having white opacities along the lungs, it may be solitary, it may be multiple. So we talked about making sure you don't miss anything. It may just be one. Sometimes some mets are even what is discovered before you start looking for the primary. Maybe having a CA somewhere, just came for a routine. You see, so this is a met. You start looking for the primary before they'll be able to discover the primary. So anytime you start having white patchy opacities on the lungs field, that's one of the presentation. But remember, that's not the only thing that presents that way. That's why you have differential diagnosis. You have the clinical histories. You have to match these things together to be able to know which one is. This bat wing appearance, I'm sure if we start talking about it, you won't understand it. You also see it in cardiac failure, can have bat wing appearance in cardiac failure. That's one of the things that we used, some differentials. There are some presentations you must have. You may have Kelly B lines, you may have bat wing appearance, you may have pulmonary congestions. These are the things, there are some things that you must see before you can be able to say, with these things, then I think there's a cardiac failure. So some of these things appear in other ones, but there are ones, if you see up to 3 or 4 of them, you can stick out your neck and say, this is it. So bat wing appearance is one of those things that, one of the differentials you look at before you can make some diagnosis. So it's not something you just come and say, this is just bat wing appearance and it's this. No, it's one of the appearances that we have in some pathological cases. Pulmonary heart failure is one of them.
Okay, I think you still have a question. Somebody is asking something about false positive. How do you differentiate? How do you identify false positive in chest X-ray?
Sorry, person may have to make it clear. What do you mean by false positive? Please, how do we identify false positive in chest X-ray? What do you mean by false positive? The last time I checked, the false positive is with the labs. When you do your, I teach a course that your, sorry?
I think from my own understanding, is about measurement, how you check the clavicle, whether it's equidistant, as in what are the things that what kind of exposure that you will see, you will know that this is not taking well, because it will be showing things, abnormalities that are not there, just because the X-ray was not done well. I think that's what this person is trying to say.
If that's what the person is trying to say, that's why we say before you start assessing any film, you have to check if it was optimally done. Remember, there are some things that, like we gave mnemonics, right? rotation, inspiration, projection, and exposure. And we said that sometimes tracheal deviation, that's what we call false deviations. We have some true deviations and false. False deviations are the ones that, mechanical. The deviation was because the patient wasn't positioned where it was rotated. So, and that can be, maybe you look at it, you just want to be sure this, you look at it, the medial end of the left and the right clavicle is not equidistant from the spinous process. And it's possible that this is as a result of, and of course, it's going to be mild. It's not going to be as much as like if you see deviating all the way to the half of the other lungs. There's no amount of rotation that can give you that. So, but when you're looking at some mild deviations, you can look at it and now be able to see, is there, of course, there's some other things that can give us these deviations up there. You can have a thyroid, there's a thyroid mass there. Though, of course, it's on the neck that will assess that. But it's possible there is even the some of those, because you're going to still get a part of the neck and the chest. That may be an indicator. They cannot request for, please do a neck x-ray. Let's assess that neck well and see if there's something going on there. We'll look at the patient clinical history. When you look at that and just seeing that patient was not well positioned, and remember, some patient's condition may not allow you to have an optimally positioned patient. So if a patient is bad, and all you're trying to do is is there perforation here? And you're there trying to check, no, the medial ends are not equidistant. No, go back. When patients have some other life-threatening things, that's not one of our problems at that point in time. The patient gets better. Some of these patients, it all depends on what the condition, what the situations are. But even if the patient was sitting down, you're just trying to get as best as you can, depending on what you want to see at that point in time. Or maybe you're looking at, why is this patient breathing this way? Why is he not able to? Or looking at, is there any lungs abnormality that is causing this? Is there really a trick? Of course, tracheal deviation we're looking at for now is that, is it a lung condition that is causing this? So having a mild deviation will not, but for an apparently healthy patient, apparently is a word, that, we have some of those deviations. You just want to, be sure that it's not that. And of course, it's not in all cases. Remember, this is radiation. It's not in all cases that you just repeat because you have small. So just look at it. In medicine, benefit must outweigh the risk. Like Dr. will always say, what question are you going to answer more if you're to do it the other way? If it's not going to answer that question, then there's no need for it. So we should just know that this is not for us to just hold our neck and be looking at the radiograph. Did he rotate? Did he inspire? Where did he not? No. So we just want to be sure that what we're calling a pathology is not as a result of failure in technique. Thank you.
Wow,
Okay,
thank
ma'am.
you so much. So much. Okay, we are going
I
to call it a day.
think I have a question.
Does someone? Okay.
Okay,
Can you be fast?
thank you very much. Okay, what I want to ask is there a case whereby a chest X-ray can be done, and after much reports from the radiographer or the radiologist, that patient will be sent to go and do CT, another modality? Then if yes, in which kind of case do this normally happens?
Okay, like we said, chest X-ray is the first line of action. So by the time a patient's condition is not well answered by a chest X-ray, we can refer for other modalities to answer. Maybe we're seeing some lesions. We're not sure if they're, if they're malignant lesions or there are just some cavitations from where. At any time that with simple chest X-ray, we're not able to, or what we believe is wrong with the patient, the clinicians have been managing and the patient is not getting better, we can, seek for other modalities. Like we know in cases like emphysema, because when you do a CT, what do we call it? When we do a high resolution chest CT, it's so beautiful. You will see there's an emphysema, you are seeing it, everything is crystal clear. But remember, we're in Nigeria most time, and of course in medicine, you don't start with the higher modalities. You start with the lower one. One, radiation. Two, cost. What's something that is lower in radiation and lower in cost to answer? Why will you want to answer with one that is higher? Remember, these patients are going through a lot. They're also spending money and they have to treat themselves. So we don't start with the higher modalities. But in any event that the lower modality is not able to answer our questions, we can, refer. And of course, there's some cases that obvious that even if you do a chest X-ray, yes, we know that is, but we want to know to what extent has the lungs been ignored this, or to what extent. Of course, and of course, when you have there are some that looks the same. When we have fluid like pus and blood, they can look the same. You want to find out if it is pus or fluid, what is causing it. Of course, it's only when you do CTs that you may be able to look at, oh, is this participation of the lung? Is this part of the lung size that and that and that? So some of those scenarios, you just have to refer the patient for a CT scan.
Okay, thank you so much. Our time is up because we are supposed to end this meeting by 8:30. Please, can we appreciate our presenter with any emoji of your choice? We really thank you, Dr. Okechukwu.
Thank you.
Just as it is with our tradition in this our cardio education group, you're going to stay with us because within the week we can still be looking at some questions, some clarification. We can throw in a clinical scenario where we expect you to, at your convenience, when you're not too busy, to throw more light on those comments, questions, and concerns. So we really appreciate you. May God bless you for being there for us and for such a beautiful presentation. Thank you so much. So the cardio group is a kind of multidisciplinary group, though the majority of the participants are physiotherapists, but we have other professionals. And the essence is for us to rub minds, share ideas, so that we don't just be on our own. So we have doctors, lab scientists, nurses, geographers, and we also have a pharmacist so that we can keep rubbing minds, sharing information, and growing and impacting positively on our skills. So on this note, I want to thank us and also appreciate those that joined us through YouTube. Thank you so much for joining. And please do subscribe to our channels, our YouTube channels. We're going to be back first week of December, and that will be the last presentation for the year. We'll be looking at the legal implication of documentation. We have a lawyer who is good at this to tell us how the way we document can put us in trouble or can save us. Documentation is very important for every clinician, and we must know how to do it right. So thank you, everyone. Thank you, Dr. Okechukwu. Thank you, Dr. Bruce. Dr. Bruce is the head of department of radiography. So I thank him so much for being there for us. God bless us and good night, everyone. See you again. But remember to be in the group. Thank you. Please, let's appreciate each other. We can unmute and say good night. Thank you so much. I appreciate all of us that came for this meeting. Good night, everyone.
Thank you so much.
Thank you so much, Dr. Okechukwu. Thank you all.
Thank
Good
you,
night.
presenter. God bless you.
Good night.
Dr. Okechukwu, thank you. Thank you. Good night.
Good night.
A wonderful presentation.
Thank you. Thanks.
Good night.
Thank you, ma'am.
Yeah.
Good
Dr.
night.
Priska, thank you.
Thank you,
Thank you so
Chidi.
much, ma'am.
Good night.
Good
Thank
night.
you.
Good night. Thank